Good afternoon, everyone. Thank you for joining us for today's Talk with Mott web chat. Our featured topic today is the ABCs of ICDs. Whether you're a parent or a relative of a child with a heart condition or an ICD wearer yourself, we hope that today's program will provide you with help and answer your questions about implantable Cardioverter-defibrillators. Our chat today will kick off with a brief presentation from our panel before we open up the floor for your questions. But please know that you can submit your questions anytime starting now and throughout the chat by emailing us at mottchildren@umich.edu or tweeting us. Our tag is @mottchildren, and please use the hashtag MottChat, which appears in the upper right corner of your screen. Today's Mott Chat will also be archived, so if you want to come back and watch it again later or share it with your friends, you can find the link to the archive later today on our webpage, www.mottchildren.org/webchats. So without further delay, I'll go ahead and introduce you to our panelists. Dr. David Bradley, Director of the Heart Rhythm Service here at CS Mott Children's Hospital, and Brynn Dechert-Crooks, a pediatric nurse practitioner on the Heart Rhythm team, also here at the Congenital Heart Center at Mott Children's Hospital. With that, I'll hand the reins over to you two to give our audience a brief overview of the ABCs of ICDs.
Good afternoon, everyone. We're so glad to have you with us this afternoon for a discussion about implanted Cardioverter-defibrillators. Those are known as ICDs, and we'll use that term ICD over and over as we're talking today. Brynn is my partner in the Heart Rhythm program at the Mott Children's Hospital, and we're going to take you through the purposes for ICDs and how they work. So Brynn, can you start by describing what ICDs are all about?
Sure. So an ICD, the point of an ICD actually is to detect and treat an abnormal rhythm. There's a number of conditions that could cause an abnormal rhythm. And so what the ICD's purpose is to actually detect a fast rhythm and shock the patient back into a normal rhythm. This is similar to what you may remember or see on TV in some of the emergency shows where a patient sometimes passes out and then requires resuscitation with an ICD. So this is all internal. There's no patches from the outside, but it does a similar type of thing. So it's based on rate and the rhythm that the device sees, and the leads that are implanted in the patient's heart would detect that abnormal rhythm, and then the device would again shock the patient out of that rhythm. There's many different types of ICDs, so I'll let Dr. Bradley go through a little bit the indications for the ICD as well as different types of ICDs that we can implant.
So I'll introduce you to the device, which is, this is sort of an example device. I hope you can see that. It's like a metal can, and we actually refer to it sometimes as the can. And in the most conventional system, in the usual ICD system, that's connected to a wire. We call this the lead. This is a lead wire, and when they're connected together, they make the system of an ICD. So the lead and the ICD are connected. And normally this is implanted underneath the skin up in the area of the upper left chest. That's the most common place, although some other locations can be chosen. The way it works is this. The wire is advanced into a blood vessel that is coming from the arm and leading to the heart. So the wire follows that path into the heart and is connected to the heart. The device is then attached to that wire in a fashion shown here. Here's a chest x-ray of a patient who has an ICD. And you can see, here's the ICD over here in the shoulder area. The wire coming from it, I hope this projects, goes down into the heart and is connected to the heart. So just like those two patches that Brynn was talking about that are used, like you see that in TV where the patient is resuscitated with those two patches, the ICD and the lead serve as those two patches, but they're inside and they're detecting the abnormal heart rhythm and they're delivering a shock when that occurs. A newer kind of ICD is, and one we really hope will become in broad and common use, is the subcutaneous ICD. If you compare this one to the one I just showed you, it is larger, it's a bit thicker, but it has an advantage. The wire from that ICD does not have to enter the heart itself. It goes underneath the skin of the chest, so is not touching heart tissue. And then the ICD goes on the side. I'll show you two diagrams to demonstrate how that one works. Here's a picture of a subcutaneous ICD. This is the ICD here, and it would be underneath the skin. And the wire goes along and underneath the skin in the area of the chest, but actually in front of it. I have a diagram of a recently implanted one in a teenage patient. And you can see there are some bandages here. There's some magic marker on the patient's skin showing where the device is located. You can see there's a bulge where this is located, but you actually can't see the wire running underneath the skin. So once again, this works a little bit differently, but it ends up being an implant for a patient and something that they take with them and is offering protection from life-threatening arrhythmias. So we place these at the Mott Children's Hospital, and Brynn is a big part of the follow-up and care. So Brynn, why don't you mention some of the things that you're talking to patients about after I've put one of these in?
Sure. Many of our patients wonder about when they can get back to activities of daily living, how much pain they're going to have, those types of things. There's actually not too many complications that we experience right at the time of implant. Some of the things that we usually send patients home with are pain medicine, which most patients take for a few days. It's really somewhat of minimal pain. And then they eventually transition to ibuprofen or Tylenol to just for some dull pain that they may have. Many of these patients tell us that the pain is actually surprisingly much less than they would have expected. The incision is not that large, and patients do fairly well after this. The other thing that we send patients home with is an antibiotic. Depending on the center that you're having the device put in and the type of the procedure that you're having would decide how long you'd be on an antibiotic for. This does help to prevent some infection, which is something that we monitor for very carefully and have parents help us figure out if a patient is experiencing any signs of infection. We actually have had a pretty successful program at University of Michigan by using kind of telemedicine where we ask families to send in a photo of their wound, a digital photo, within about 1 to 2 weeks after putting the device in. That allows us to have close contact with the family, to talk to them about any signs of infection, and also get a pretty good look at it with the digital camera. If we have any concerns, then we may ask the patient to come back to have us take a look at it, or we may ask them to go see a primary care doctor closer to home. Some of the signs of infection that we routinely discuss with parents are a fever that may not be related to an illness such as a cold or a cough, so a fever kind of out of the blue, any redness at the site of the incision, or any unusual drainage. In some cases, it could be pus, sometimes it can be a little bit of blood, and so we ask parents to call us with anything unusual. Sometimes patients also have a significant amount of pain, and that can indicate infection. So with anything that's unusual or out of the ordinary, we try to keep a close tabs on these patients and have them call us with that so we can treat it as needed. Down the road, we think about things that are associated more with the device. So there can be inappropriate shocks, meaning a patient has a rhythm that's not life-threatening and they get treated for it from the device. We're hoping that this will improve over time because the new technology actually decreases the risk of inappropriate shock with new algorithms that the device can go through. But there is still this risk. And so we do take this seriously, and we will reprogram the device as needed or kind of look into the patient a little bit more if they're experiencing a shock that wasn't intended to happen. And then we also talk about reoperations with families. So some of these devices can get recalled, or the leads can get recalled, and your physician would notify you if this were to happen. In many cases, these can be treated with more monitoring or some reprogramming to the device. But in some rare cases, more substantial operation would have to be done. These devices last about 6 to 8 years, and the removal of the device, the removal of this can that Dr. Bradley was just showing you, and then a replacement of this is a pretty easy surgery. This takes about 1 hour to 2 hours, and these patients are mostly discharged home on the same day. And so, you know, again, some of the maintenance of the device is not that big of a deal, and we again will follow this pretty closely. And I'll let Dr. Bradley kind of go over how often we follow these patients and what their follow-up plan is after.
So as you can see, a lot of the follow-up is an exchange on the phone and by other telemedicine between people like Brynn on our team and patients. But there are some times when we'd like to have patients in to see us when they come in for a check of the device and for check of how they're doing. We may evaluate how their medicine doses are. We may evaluate how their wound is doing. And then we also put a sensor over the device and read out its memory. The device has a lot of memory, and if there are abnormal heart rhythms that have gone on, since we last saw the patient, those will be evaluated. So we fine-tune the programming, and we do that every 6 to 12 months for patients whose devices are doing really well. The remote monitoring that is available through these devices is a really great recent development. There are monitors that are at the patient's home and can be used to determine if there's anything going on with the device, and automatically send us information on many patients' devices, because this allows us to see the patient less in person, but provides us the same information from the device.
And this is something that we would provide. So before you go home, you actually take home a piece of equipment that would allow us to communicate with your device at home.
That's right. So I think we've talked a little bit about the devices. I think we'll spend just a few minutes talking about the conditions that lead to somebody needing to have a device, and then take questions from the audience. So the first general category of abnormalities that lead to needing an ICD are called channelopathies. That's the first of many mouthfuls that we're going to throw at you this afternoon. Channelopathies are problems with the heart cells. The cells allow electrolytes in and out each heartbeat, and when the channels that those electrolytes pass through are abnormal, there is a risk for an abnormal rhythm. So the first one is called long QT syndrome. Long QT is abbreviated LQTS. Long QT refers to a finding on the electrocardiogram. So I'm going to show you a little example of those heartbeats that I think we've all seen in some context. So here in row A is what's considered a normal beat. The big spike is the bottom part of the heart beating, and what follows is the T wave. So this little bar shows you what we measure as the QT interval. In the patient with long QT syndrome, the interval is much longer. The spike isn't really very much different, but the T wave is a lot longer. When we see that, we consider that a sign of a possible risk of an abnormal rhythm. Not every long QT patient requires an ICD, but those patients who are considered at significant risk, or some who have experienced a life-threatening event, may be recommended to have an ICD. I'm going to show you one other thing that goes on in long QT, because this is really what the ICD is designed to detect. This is a tracing of a patient who has long QT syndrome. The regular beats, there's two tracings of those beats. The regular beats are just clicking along, and then you can see there's a disorganized, rapid, and kind of wavy heart rhythm that occurs. This is the abnormality that the ICD is supposed to find, and when it's shocked, it can go back to this normal heart rhythm at the end. Are there any other conditions we want to bring out here today, Brynn?
We can talk about a few more here. So I'm going to put another mouthful in here. One of the other channelopathies that Dr. Bradley was talking about is something called catecholaminergic polymorphic ventricular tachycardia. Long words there. The short version of this is CPVT. CPVT, again, is one of those things that can be genetic, which I think we'll get to in a little bit about some of the genetics of this. And the characterization of this is an abnormal rhythm from the bottom chamber that occurs with stress, like activity type stress or emotion. So this rhythm we would not notice on a regular EKG. It would be something that would come out during some of these key points. Again, that's adrenaline-like activities like running or being very emotional about something. So again, it's characterized by an abnormal rhythm from the bottom chamber. This is an example of the rhythm that goes along with CPVT. We would call this bidirectional ventricular tachycardia. Again, another long word. And here you can see that the rhythm is quite irregular. And again, the device, the ICD for this rhythm would detect this and shock the patient out of this rhythm. In some cases, these patients actually can come out of this rhythm on their own, and the device would not have to shock them for it, but the device actually records this rhythm. So like Dr. Bradley was saying, when we do remote monitoring, we could see if there was any shorter episodes that didn't need to be treated, and that could help kind of decide what we need to do for these types of patients. This is not something that's that common. It's about 1 in 10,000, but it is something that we see in our electrophysiology clinic at University of Michigan. Another condition that we often see in patients at our center is something called hypertrophic cardiomyopathy. So this picture here over here is actually the abnormal one, and then this is the normal side over here. So a heart muscle is made of 4 chambers, and there's walls between the 4 chambers. So this picture here shows a normal ventricular wall, which is somewhat thick because it actually has to pump the blood to the heart. And then this side over here actually shows an abnormal thick septum. So because of this thick septum, these patients can actually have ventricular tachycardias. Not all patients with hypertrophic cardiomyopathy need to have an ICD. Some of our patients do, but not all of them. And this does occur a little bit more frequently than CPVT. It's about 1 in 500, and it is currently the leading cause of sudden death in athletes. And so we do follow these patients pretty closely to make sure their wall between their heart isn't getting too thick.
So those are some of the best known conditions that lead to needing an ICD, although we actually take care of a number of patients who don't have those diagnoses. Some patients need an ICD years after they've had a heart surgery, that they were born with a heart defect that led to surgery, and the surgery itself and scarring led to a heart rhythm problem that requires an ICD. In other patients, the exact cause of their abnormal rhythm isn't known, but the rhythm has been seen, and an event has occurred, and an ICD is felt to be the right treatment for them. So I'd like to just talk briefly about the symptoms that lead to the ICD, the symptoms that make us even think of these diagnoses. I guess the most important one to talk about is fainting, because actually fainting happens a lot. Many of you may have fainted, and fainting happens in a harmless way quite frequently. Sometimes, for example, if a person's standing for a long time on a hot day, they may have a faint and recover promptly, and it doesn't mean that there was anything wrong with the heart. Once in a rare while, there's somebody who faints or has seizure-like motions during activity or during excitement. That might be a sign that one of these rhythms has occurred, because when the heart's functioning poorly with these abnormal rhythms, the blood flow to the brain isn't good, and so the patient loses the ability to stay alert, or even has like seizure movements, involuntary movements of the arms and legs, and then recovers. But that is a very important sign and requires us to look more deeply.
I think now we can move on to some questions if there are any out there. We'd love to answer any questions you may have.
Sure, we'll start with one that's been submitted over Twitter. The question is, how often should the ICD be replaced?
It's a good question, actually.
Let's take that.
So the device, these batteries, so there's 2 parts of the ICD. It's the battery and the leads. So these batteries last about 6 to 8 years for most of these devices. It depends on how often you use the device and how much you need the device for. These leads can actually last many, many, many years, much longer than the device. And again, when we do remote monitoring or checks in the office, it tells us how the leads are doing, how they're functioning, if we need to replace them. And it also gives us how much battery life is left on these batteries here. So I would say about 6 to 8 years, and it is always dependent on the type of device that they have and the reason they have it and how often they're using it.
That's right. And actually, I should say that when the devices run out of battery, they don't just stop. They actually give us plenty of warning, and many of them make a noise or vibrate to indicate that it's time to get this thing checked out. So long before they would be unavailable to help the patient, they're giving signs that it's time to replace them.
And like Dr. Bradley said, this is actually an audible alarm that the patient would hear. And we would also get a warning over remote monitoring, but the patient could also hear that alarm as well.
Well, that may actually answer another question then that came in over Twitter, which is, how do you know if the ICD is working or not? You mentioned a sound. Is there anything?
Yeah, I mean, I think that's exactly right. I think being aware of what type of alarm your device has is really important, because the alarms are very sensitive, and they let you know. And I think keeping the home monitor functioning properly is also very important. Some people have a wireless monitor where they actually don't need to do anything for problems with the ICD to be automatically transmitted to the doctor. Knowing how that all works for your device is very, very important. But I think you can presume that if there are no alarms and you're feeling well, that it's functioning well.
And there's different types of alarms. Our recommendation, I think, is if you ever hear an alarm or have a concern, you can always give us a call. We can always take a look at you in the office, or we can have you send a remote monitor from home. But there are different levels of alarm, things that we would act on more quickly than others. And I guess the best advice is, if you're ever worried about something, just give your physician or their office a call.
That's right.
Another question that has come in here: can you play sports with an ICD?
I'll let you answer this, Dr. Bradley.
Okay. Well, this is an area of a lot of controversy, and I think one of the things that's hardest about knowing what's the right recommendation for a patient is knowing full well that another doctor may make a slightly different recommendation. So we're learning that people with ICDs can actually safely be involved in a lot more activities than we originally felt. But there are usually restrictions based on the device and on the condition that the patient has the device for. We've actually, unfortunately, we're aware of Olympic athletes who are competing with an ICD, which we feel may give the wrong message to the majority of patients for whom that level of participation wouldn't be possible. But we think that for almost all patients, some light degree of activity, some enjoyment of physical activity is possible. And then it really is customized to the medications and the condition and the type of device that you have.
We have another question related to a specific type of device. This person asked, I have a St. Jude ICD, but I've heard a lot about a Medtronic ICD. Is there a better device?
Do you want to answer that, Brynn?
So we use several device companies. Several device companies make ICDs, and for different patients, different device companies have different they have different specialties, or they have different programming that we may choose one over the other. But I don't think, and Dr. Bradley, you can correct me if I'm wrong, but I don't think that there's a superior type of device company out there. It depends on, again, the reason why you're getting the device, the options that you need on that device, and other reasons, like, do you have veins that we can put it through your vein, or do we need to use a subcutaneous ICD for other reasons? So I don't think that there's a superior device company. And at University of Michigan, we actually do have devices from all the device companies and can follow them easily.
Yeah, I think that's right. I think implanters generally use what they've been used to, but there are features that differ between devices. So I think that's a good answer. I think in the United States, we're lucky to have a number of manufacturers that offer very good devices.
Okay, another question. You mentioned that some of these diseases are passed down in families. Is there a test for these diseases?
Okay, that's a great question, and I'm glad we're talking about it, because yes, we didn't really get into the family history part, but many of these conditions, in fact, all the ones that we discussed specifically have a genetic component. That means they can be passed down through families. For the majority of the conditions, they're called dominant inheritance. That means that they're passed on in the following fashion. I have a little diagram because I thought this might come up. And if you look here, this is the parents, and unaffected is the mother in this picture. So she's a darker blue, and the affected parent is in the lighter color. So if they had 4 children, the statistics would predict that about half of those children on average will be affected. So you see that there's 2 kids, a boy, a girl, that are not affected, and 2 kids that are affected. So about half of anybody's children is likely to receive the possibility of having the disease. But it doesn't travel through families in a really consistent way. None of these conditions are exactly the same in a child as they were in the parent. And as you can imagine, you may have a large family with cousins and various affected people. And so we can do a gene test to find out whether they received the abnormal gene, the abnormal genetic material that came from the person who was affected, the parent who was affected. By identifying those people, we don't conclude they got to have an ICD, but we realize that they need special observation and determination of what kind of treatment they need. Are there any other points about genetics that I should have mentioned, Brynn?
So I think the next kind of point to make is there isn't a test, or there is a blood test that can help us decide if other family members would be affected, but sometimes this blood test isn't 100%, and we actually in our center have a genetic counselor that can help us order these tests and interpret these results with the physician and at least contact families to let them know how this may progress through the family or how it would affect other members of the family. So we have a good comprehensive team that's able to do so, and can help us with that.
Yeah, I think that's right.
Okay, another question in through via Twitter. Will an ICD change my child's quality of life?
Very good question. We get this question asked all the time. There's actually quite a bit of research out there about quality of life. And what we found is actually kids do pretty well with this. I think one of the most recent studies shows that if you're older when you get the device, you may have a little bit more of an effect than when you're younger. I think kids are pretty resilient. If this is all they know, it doesn't bother them so much. And each patient is different. So we haven't found a huge problem with the decrease in quality of life with the IC itself. Some patients can actually have anxiety related to learning about the diagnosis or learning that there could be a problem more so than the device. But again, I think children are pretty resilient and can kind of get through this. And there are a few people, or there are people out there that do, get affected by this. And there's actually, I think, some resources that we can talk about in a little bit. But I think that kids do pretty well overall.
Yeah, I think that's right. And I think, you have to support the individual needs of the people involved, because it's a complex thing. The parent is dreadfully fearful of a life-threatening arrhythmia occurring in his or her child. The child may actually not have that as the biggest concern. The most immediate concern to a young person may actually be the effect on their body, a scar being present or something being visible or someone knowing that they've got some significant medical issue. And so we try and address those issues, try and discuss those before and after the implant, and we try and make the implant as discreet as possible with a scar that's as well hidden as possible. And we have a number of support opportunities, and we'll go into that just a little bit later, that we hope address needs of both the parents and the children.
But we do try to encourage normalization of activity as much as possible, because as you know, in teenage years and younger than that, kids want to be normal, so they don't want to be treated differently. So we really try to work with schools and educate schools as we need to allow these kids to do their normal activities and not be singled out as someone abnormal. And so we talk with school nurses and principals and teachers and things like that as best as we need to. We do that obviously with the parents. We would never call a school on our own, but it's something that we do regularly, is talk to any sort of support staff at the child's school or anywhere else that they may regularly go to, daycares and things like that.
Okay, let's see, here's another question. Do microwaves, cell phones, or security systems affect how an ICD works?
Shall I answer that one,
Please
Brynn?
do.
Okay. So in the early days of microwaves, those were also the early days of pacemakers, and there was a problem for certain patients to be near a microwave oven when they had a pacemaker. But those days are behind us. The modern devices, pacemakers and implanted defibrillators, or ICDs, are entirely compatible with the usual use of kitchen equipment, including microwave. There are some sources of electrical interference that can temporarily make an ICD not work right. Those are very infrequent, and an example is a certain kind of welding. So there are some people whose livelihood was welding, and they can't do that after they get an ICD. But very few people are highly restricted, and actually most tools, most electrical appliances can be used without problems. People also ask about magnets. Magnets do have an effect on an ICD. A magnet placed over an ICD changes the way it senses arrhythmias. It's important for you to understand how a magnet works with your device and to talk about that with your doctor if you think you're going to be near very strong magnets. However, being near speakers, being near refrigerator magnets and that kind of thing is really of no importance. One last item to talk about is music players and cell phones. Those are everywhere today, and their effect on ICDs is also very, very minimal. Standard advice for a patient whose ICD is in this location is that they speak on their phone on the opposite ear. But in reality, I think we know that the chance, even when the other ear is used for phone calls, the chance of a problem that's permanent is zero. The chance of a temporary problem is extremely small. So once again, something to clarify with your doctor, but a very minimal concern.
I often get questions about travel. So people going on airplanes and things like that, or walking into a shopping mall when there's security systems and things like that. And what we tell our patients is if they walk through the security system at a regular pace, just walking through, the chances of it affecting the device is very minimal. So you can go on an airplane, you can go through the airport security system. And I know the questions I've gotten more recently is the new x-ray machines, especially at Detroit Airport, when patients are going through those, will it affect the device? And that actually will not affect the device when you stand in the x-ray machine. And so we do allow patients to travel without restrictions, and they, again, can go into shopping malls and, government buildings and things like that without being worried about things. But if there's ever a question that you're going to be by a new type of equipment, or you have concern about it, the staff at your hospital or the physician can answer those questions and actually look things up to decide if that's something that you should be worried about or not.
We mentioned airports, and so that's actually related to a question we just got over email. This summer, we're taking the plunge and going to Disneyland. First time the little guy will fly with an ICD. Anything else we should keep in mind, or general travel tips?
Well, I'll answer the ones I can think of, and then I'll see if Brynn has some other thoughts to add. I think when it comes to riding amusement park rides, almost every amusement park ride at an established park has actually been checked, and the voltages and exposures are actually low enough not to cause a problem with the device. Some doctors will advise patients who have certain conditions not to ride very exciting or frightening rides. And I think that's the part that needs to be discussed with your individual doctor. But in general, there are no significant hazards that I can think of for that kind of a vacation. The air flight should be okay. The hotel environments and the rides should not cause any significant issues with the device. Brynn, am I forgetting something?
So we actually get questions about people taking their remote monitoring equipment with them on vacation. And unless you're taking a 6-month vacation, we actually don't recommend that you take your device, the remote monitoring box with you. First of all, with luggage costs, it could be quite expensive. And if you're gone a week or so, the likelihood of something happening to the device is very minimal. So we usually say that's not necessary to take your remote monitoring box with you when you go to Disney or anywhere else, even abroad. Again, that would be very difficult to plug it in if you were overseas or something along those lines. The other thing that we recommend that you have with you, which I think most people do, is you get a card that describes what type of device you would have and the model and the make of the device. Those the companies, it looks like a credit card, and this is something good to just have in your wallet. So in case you were ever to need to have the ICD checked when you were away, at least they knew the type of device that you have. And again, this just regularly comes from the company, and it's updated. And again, it's about the size of a credit card, so it can just be easily shoved in your wallet or your purse.
All right, we have a few questions related to a specific condition, long QT. The first one, my doctor has recommended an ICD for me. Is this something I need? I've never passed out before.
Do you want to answer that one?
Okay. So the decision to put an ICD in a patient with long QT is pretty complicated, and it's not the same today as it was 10 years ago. So I think that we have found that we have a better idea by various testing who is at greatest risk for needing an ICD, who's at greatest risk for a life-threatening arrhythmia. Some patients do require an ICD based on the type of long QT they have and the various things that have been found on their testing at an early stage. Fortunately, the number of patients who are needing that upfront is decreasing. And so once again, I think it really depends on some specific information related to you and your long QT.
And I think this goes for any diagnosis, not just long QT or CPVT, any of those. It's all individualized. All the genetic testing we get gives us very specific results. And I think that your physician can help you navigate to what the recommendations would be. And again, we don't take this lightly. We do a lot of research and do a lot of discussion about whether the ICD is implicated for certain types of patients.
Another question that we got via email from a patient with long QT, is an AED something I need at home? And maybe also, in case our audience isn't familiar with an AED.
you want to talk about that a little bit, Brynn?
Sure. So an AED, another couple letters we can throw at you, stands for automatic external defibrillator. And those are what you see in the airports, in schools, in government buildings. It's about this big. It's usually red, and you usually have to break the glass to get into it when you're in a public place. Some centers would recommend having AEDs for families, and some others wouldn't. They are expensive. They're about $1,500 to $2,000. So I think probably the best thing to do is discuss that with your physician. They can let you know what the risk is and then help you decide if that's something that you should have for your family. What we're finding through different projects like Project Adam and things like that is AEDs are popping up in all sorts of different places like schools, gyms. So we really are trying to get AEDs in public places. And I think many school districts around Michigan, there's the Heart Safe schools that would have AEDs. These schools are especially trained in using AEDs. So again, I think we're starting to get into an era where AEDs are prevalent everywhere. So hopefully families wouldn't need to have individual ones.
Okay, another question. If we've had a family member die suddenly and are not sure the cause was really fully explained, how would we start to find out if our family is at risk, and what should we do?
Go ahead.
Okay. This is a scenario that comes up a lot. If the family member has children, those children should see a heart rhythm specialist appropriate to their age. At the University of Michigan, for example, we have the pediatric group, of which we are part, but also colleagues at the Cardiovascular Center who do exactly the same work. And in fact, there is an interchange between us so that when there are adult and child members of a family, we can care for them in a coordinated fashion. But I think a sudden death, an unexplained death, it does merit a trip to a clinic, even if it's only one time, to make the evaluation, to gather the data, and where necessary, to do additional testing. There are actually gene tests that can be performed in certain situations when there's a high suspicion to look for something that might be running through a family. So these are exactly those types of conditions, and it is definitely worth having close relatives checked. Relatives further out than cousins, however, are probably not at significant risk. So it's really best to bring in the closest relatives to the person who's died.
If there's concern, of a sudden death, we can help you navigate how to get in, where to go. Again, we have genetic counselors that can help us with that kind of thing as well.
Okay, another question that came in through Twitter. What does an ICD shock actually feel like?
Go ahead.
Okay, well, I don't have an ICD, so I will have to go on the reports of our patients. So in the best circumstance, or the one you kind of want the ICD for, the patient may actually not be conscious. They may not even be aware of a shock. And so there are some patients who will come for a visit and not be aware that they received a shock from their device. In a way, that's the intended way for it to go. But inappropriate shocks, or once in a while, a shock may occur at a time when the patient has not fully lost consciousness and they're aware of the shock and they feel a jolt. It's a kind of an abrupt movement in the chest. It is not like an electrocution. It's not like a shock. People don't feel that pain, but I think they feel the jolt, and they feel it in a manner that is not expected. And so it's actually the surprise that is most memorable, and for some patients somewhat disturbing. It's for that reason that we emphasize and we put so much focus into getting things right so that the chance of an inappropriate shock is minimized.
Okay, another question from Twitter. Any advice on how to help a child who is having a problem adjusting emotionally due to their ICD?
Great question. That's a great question. So like I was saying earlier, kids are pretty resilient, but there are a lot of people out there that this does bother. And so at the University of Michigan and in many other places too, we have a support group specifically for this. This is called the Young ICD Support Group or Conference, and we hold it once a year in coordination with the Cardiovascular Center. And this support group or the support conference can actually help the child feel better about their diagnosis, as well well as they're having an ICD. They mingle with other kids with similar diagnoses who also have ICDs and can tell them how it's been going for them, how they've adjusted, because obviously every kid is different and they may need a little bit more support. And so actually peer-to-peer support has been very good for us. At our conference, we actually have patients tell their story so other patients can relate to them and understand how it feels or how they felt when the ICD was implanted, or how they've been treated at school and things like that. And we're able to give people real advice on how to get through this. There's also support groups that we hold for parents and siblings, as well as other family members of patients with ICDs. So this is a conference for the whole family. This year, we're going to have our conference in October. It's usually in the fall. It's going to be on October 3rd, 2015, and it goes all day. It usually starts about 9 a.m. and we finish about 6 p.m. in the evening. We have all sorts of fun activities for kids, as well as support for family members and siblings and anyone who wants to come. So we really do put the emphasis on the family here. It's not just the patient. So this is a great way to get involved and have your child understand how other patients are doing. The other thing that we can offer at our center anyway is hooking patients up with other families who may be in the same situation. So if you were to call our office and say, you know, my son is really struggling, do you know of anyone that would be willing to talk to them? We do have parents who are always willing to be peer mentors, and we would call and ask permission, but we've had a lot of success with hooking parents up with parents or kids up with kids that are the same age and can kind of talk them through it. At the Cardiovascular Center, they also have monthly support groups for older people with ICDs. We haven't gone that route yet. We do have a very good turnout at the Young ICD Support Conference that's held once a year. But again, we can offer individualized care for any child, and we can also do any sort of referral to psychiatric centers or anything like that that can help a child kind of get through it.
And I should mention that that conference is actually open to patients and families from any medical center.
Right.
We welcome people from across the country, and I think we've seen time and time again how they may not have been sure what they were to come and hear, and they may not even have thought they wanted to hear the tales of a patient, what they've been through with their illness. But so many of them leave their first meeting with a huge load lifted from their shoulders as they realize all the kids around there are family members or actually patients with ICDs. And it's almost like being at school, but all the kids have the same kind of problem you have. And I think it's a great realization for the patients. So patients from everywhere are welcome, and we can give you details if you call us at the Mott Children's Hospital.
And we also actually have a Facebook page for our Young ICD support group that can, again, get you peer-to-peer relationships with other people who have similar type of diseases or kids who may have this. Our Facebook page is, again, a Young ICD Facebook page, and you can't just jump on it anywhere. We do have a person that mans it and allows you to join. We don't intend to exclude anyone. We just want it to really stay more confidential, and again, have the intent, which is to support other people. And so this is something you can get online and find information for out there. There's also a book that the University of Michigan has out there that actually tells some of these stories that you can also, if you go to our Young ICD support Facebook page, you can get more information about those books.
And if you're having any trouble finding any of those, you're welcome to send us an email at mottchildren@umich.edu. I understand you guys also have some other websites that you recommend for patients.
Yeah, so some of the other websites that we find helpful is the SADS organization. SADS stands for Sudden Arrhythmia Death Syndrome, and this organization was started many years ago, and it's actually has lots of information for parents. There's also a place on there that's called Online Community, so you can sign up for their newsletter. They actually have a conference every year for patients just like this, and again, it seems to be both educational and supportive, so we do have educational talks at the SADS conference, as well as some support as needed. And this conference is held all over the United States. This year it's held in May in New York. And if you go to the SADS website, which is sads.org, you can get information from about patient education or family education, as well as finding support. You can even find physicians that care for these types of conditions in your area. The other one that we find helpful is something called asktheicd.com. And this website actually can give you, it is sponsored by Medtronic, which is one of the ICD companies, but it does give you mostly non-branded information about ICDs, what they're used for, how they work. It is very interactive. There's lots of diagrams and drawings and things that you can learn from it. So we actually think this is a pretty fun website that you can get a lot of information from. I'm going to let Dr. Bradley talk about one of the other ones that's important, which is the qtdrugs.org.
That's an important point to bring up. Yes, this last site that we've put on the screen, www.qtdrugs.org, that actually links to another site as soon as you type it in, but it'll get you to a list of medications that are felt to be things that should be avoided by patients with long QT syndrome. And actually, there may be for other conditions medications that should be avoided, but this is a comprehensive and up-to-date list that patients can refer to. If they have questions, they should always call about them, but it's a guide because there are over-the-counter and prescription medications that should be avoided by long QT patients. And we use this ourselves. We can't memorize this long list, and we feel that they've done an excellent job of maintaining it.
Yeah, and the other thing is it's an up-to-date list. So if there's any medications that have been added or taken off, this is the way to find it. And again, it's a long list, so no one actually would know all this. And this is a definite way to be your own advocate, is to have this kind of website in your pocket.
We have another question that's coming over email. If you have an ICD, is it ever necessary to also learn CPR?
That's a good question. So my opinion actually is that people should know how to do CPR, and I think that's a helpful skill for many people. I don't think that just because you have an ICD, this changes that kind of knowledge of knowing how to take care of someone if something were to happen. So when we put an ICD in, we wouldn't routinely recommend CPR, but I know that there are some centers out there, and I think it's a good point, or a good kind of skill to have, is learning CPR. The problem with CPR is if you learn it once, every couple of years it changes. So the CPR, you'd have to keep up and make sure the CPR that you're doing is one that's currently recommended, and so just kind of keeping up and making sure you're getting the best knowledge of how to do CPR. I don't know if you've had anything additional to add.
No, not really. I mean, I agree with you. It's got value across the board. I think the recommendations in pediatric centers may be a little bit different than adults. But I think it also gives you an appreciation for how the ICD works and the anatomy that goes with that. So CPR is a good thing. Probably not essential to the patient who has an ICD any more than for the population as a whole.
And that leads to another point, is I do have had questions before about the use of an AED with an ICD. So if for some reason the ICD didn't appear to work and the patient was still faint, would you use an AED? And actually the answer is yes, because the AED can determine if there's an abnormal rhythm. Again, the AED is the external defibrillator that you find in government buildings and things like that. So we would still say to place the AED pads and use it if that was necessary.
Well, that is also a perfect segue to another question that we got in here. Someone inquiring, you mentioned Project Adam earlier in the chat. If you want to explain a little bit more about what Project Adam is.
Go ahead.
Why don't you answer that, Brynn?
So Project Adam, and I think you'll have to kind of add some more things. And the goal of it is to get AED kind of promotion and knowledge out there. It's something that we're part of at University of Michigan, and many other hospitals and centers and communities are a part of. But I think it's just the awareness of sudden death in the community and how to prevent that. And there's other foundations that can get AEDs to different places as needed, one of them being the West Leonard Foundation and things like that. Do you have anything else to add about Project Adam?
Yeah, I think the spirit of Project Adam is emphasizing the important role that AEDs have in preventing deaths, that we realize that there are some limitations to the other ways that we can theoretically detect a child's risk, and having the safety net of an AED in a place where events may occur is of huge value. And Project Adam has led to life-saving resuscitations of children across the country, and we're glad at the University of Michigan to be very involved in that, and to have a number of community benevolent organizations that have provided AEDs to schools. So it's really an important new emphasis over the last few years that's made progress in our state.
And there's more information also about Project Atom on our website, and that the link to that particular page is www.mottchildren.org/Project Atom. Again, if you have any trouble finding any of those pages, please feel free to email us or tweet us, and we will get you the direct links. Do either of you have anything else you want to add before we wrap up today?
Well, I guess I'll make one comment. Since we brought some example ICDs with us, we'll just show you some of the progress that's been made, because I think one of the things, in addition to seeing the happy faces of patients who've been properly treated and remain safer because of ICDs and other related treatment, we've also seen the technology come a long way, and it has not been without problems, but we did bring some demonstration ICDs, so I thought I would at least share what an early ICD looks like. So this is really big and really thick, and now let's put that next to one of the more recent models. Just a huge change in the size of these devices, and so a big difference for the patients who receive them. We benefit each time new research is performed to develop both the technology and our understanding of when the devices should be used, and we're excited to be part of this this technological field.
Yeah, I mean, we do deal with a lot of changes in technology, so we have to keep up with kind of what's out there. Patients often ask, why can't the battery be recharged from the outside? And I think Dr. Bradley can kind of answer some of the older versions of how they were, not that you're that old or anything, but I think there was at some point some sort of lithium battery or something that could be recharged, and it didn't work very well. I think I remember those stories or something. But really, the circuitry and the technology just doesn't allow actually those batteries to be rechargeable. So again, we do still rely on changing these batteries frequently, because it does take a lot of battery to actually charge or store a charge and actually shock the patient out of that abnormal rhythm. I don't know if you have anything else to add about that. I get this question all the time: is why isn't there rechargeable batteries if there's rechargeable batteries for everything else?
Yeah, so we're seeing the sizes of the devices get smaller, but ultimately they do need a battery at the current time. And recharging technologies, as well as some others, are being developed. But the reliability of these batteries is very, very good, and of course reliability is a high priority. So it'll take an awful lot of development and testing before a new type of battery is available for the devices. So we look forward to the improvements, but we're also pretty satisfied with some of the things that have gone on in the current platforms.
Right. We have one last question that we'll squeeze in here before we wrap up. Is a heart attack the same thing as cardiac arrest that would require a shock? And if you're not sure if the patient has arrested but they're not responding, what should you do? So
the term heart attack is kind of a broad two words, I guess. I get that term from all sorts of different people, and I'm actually never quite clear on what they're referring to. Heart attack, in my mind, is low oxygen to the heart, and it's not able to perfuse the heart. Some people use the term heart attack when patients have an abnormal rhythm from the bottom chamber. So again, I can't really differentiate unless I know the story behind what has happened. And I think the second part was resuscitation about it. So how do you know what to do if someone is on the ground and you don't know what to do? Actually, what you do is follow the CPR guidelines and put an AED on that patient. The AED is able to detect an abnormal rhythm and it would provide an external shock if that was necessary. The AEDs are very smart. They're very simple. It can walk someone through how to use them. They are meant for non-medical staff. Again, you just put these pads on the patient's chest. It talks you through it. It tells you what to do. And I think that's probably the best solution. Is if you come across someone that is needing help, of course you would call 911, but if there's an AED nearby, get that on the patient.
That's right. I think calling for help is the immediate action if possible, and identifying an AED if it's available. But it's time that is the big issue. And if responders who have an AED can get to the scene as quickly as possible, the best result for the patient will occur.
Okay, well, I just would like to thank everyone online who joined us today, all the great questions that were sent in, and a big thank you to our panelists, Dr. David Bradley and Brynn Crooks-Dechert, both with the Congenital Heart Center here at CS Mott Children's Hospital. You can learn more about both of our panelists and the Congenital Heart Center here at the University of Michigan by visiting www.mottchildren.org/congenital. You can also call us toll-free 1-877-475-MOTT. For all of our registered participants, we'll be emailing you a link to a survey for your feedback about today's chat, and we would really appreciate your taking a few moments just to share your thoughts with us as we plan for future chats. For those who just joined us spontaneously today, you can also take the survey at umhealth.me/ICD survey. And with that, I just thank you everyone and have a wonderful afternoon.